Hi everyone. This is the last part or installment of the regional anesthesia section for the advanced exam, part 7, which is going to focus primarily on neuraxial anesthesia. Most of the focus on neuraxial anesthesia was more for the part 1 basic exam, but it does reappear in the advanced exam. It's not exactly clear what the ABA wants you to focus on with respect to neuraxial anesthesia. More of it's related to complications than anything else. So we're going to sort of review a lot of that. It'll be redundant compared to some of the elements I described in the part 1 lectures related to this. But it's part of the frustration of studying for these exams. Stuff appears to be inappropriately placed in the basic versus the advanced, and in some cases they appear in both, much like what happens with invasive monitoring and things like that. So just for the sake of being complete, we'll review all of this in case any of these show up as keywords on your exam. So I'm talking about physiologic effects and complications of neuraxial anesthesia. It's a brief review of your anatomy, which you know all too well. You have from skin all the way into your neuraxial structures, the supraspinous ligament, the interspinous ligament, which would be right here if we're cutting through it, but here in a spinous process, of course, and ligamentum flavum. And then you would end up past the ligamentum flavum in the epidural space. And then the dura mater, of course, which then beyond which you would see the subarachnoid space with the nerve roots here. Okay, the posterior longitudinal ligament is the anterior border of the epidural space. And so these are different views from Miller's anesthesia of these anatomic structures. And I'm not going to spend a whole lot of time talking about these. You can certainly review them from the Part 1 exam content if you need to refresh your memory. But by now, if you're sitting for the advanced exam, you know the anatomy of the neuraxis pretty well. So how does sympathetic blockade compare to sensory blockade during spinal anesthesia versus epidural anesthesia? Because hypotension is obviously a significant side effect or complication from spinal or epidural anesthesia, especially if you have a total spinal. So overall, your sympathetic blockade, the sympathetic nerves are far more sensitive than the sensory nerves that are even themselves more sensitive than the motor nerves. And with spinal anesthesia, the sympathetic blockade may be 2 dermatomes, classically taught, or as much as 6 dermatomes higher than your sensory level. So it's pretty hard to avoid hypotension during spinal anesthesia if you're not going to treat it. Overall, with epidural anesthesia, you basically get segmental anesthesia, and the level of sympathectomy is typically somewhat tracking along pretty much on par with where your sensory level is. So, as I said, 2 to 6 dermatomes above the sensory level with spinal anesthesia, approximately the same level with epidural anesthesia. A lot of this hypotension results from a loss of venous tone, which comprises about 75% of the total blood volume in your veins, and venodilation is what causes the loss of preload and then consequent loss of cardiac output in hypotension, not as much related to arterial tone. The total peripheral resistance, or SVR, should decrease about 15 to 18% in healthy patients, but as much as 25% in spinal anesthesia for elderly patients. Cardiac output might decrease by about 10% or so. Bradycardia, another concern of neuraxial anesthesia. Most of the time, slower heart rates that result from spinal anesthesia are related to something similar to, for example, the Biesel-Gerisch reflex. You get a fall in atrial filling resulting from the venodilation and loss of preload, which ultimately activates stretch receptors located in the right atrium to induce a vagotonic response and slow the heart rate down to ultimately increase filling time. So it's an odd reflex. You would want higher heart rates with higher cardiac output because heart rate times stroke volume equals cardiac output. But this is a right-sided reflex which aims to increase filling time in response to a low preload. Secondarily, you can get cardiac accelerator fiber ablation if you get a really high spinal all the way up to T1 because the cardiac accelerator fibers come from T1 to T4. And then lastly, if you're treating someone that's currently in pain and you take away their pain and consequently they're circulating catecholamines, their heart rate might slow down. They might not become overtly bradycardic, but that's a third mechanism that logically would arise from treating ongoing pain. So overall, the decrease in blood pressure after neuraxial block can be minimized by use of vasoconstricting agents like phenylephrine. It's really not as effective to preload the patient with crystalloid. It's not a reproducible effect to maintain normotension utilizing that sort of approach. So, primary respiratory abnormality that occurs with neuraxial anesthesia. I go over this frequently because people may not appreciate exactly what happens from the respiratory standpoint with neuraxial anesthesia. Overall, when you employ neuraxial anesthesia, you typically get mid-thoracic to high thoracic levels, which take away the muscular tone of the chest wall and abdomen. So you lose your obliques, your abdominal, your rectus, your intercostal muscles, all of which can aid in expiration. You typically do not influence inspiration, because inspiration is governed by the diaphragm, which comes from C3, 4, and 5. So unless you have a total spinal, you're not impacting tidal ventilation or inspiration. Expiratory reserve volume is typically the volume that's most likely affected by neuraxial anesthesia. So anything that involves expiration is what ultimately gets affected. Tidal volume is unchanged, vital capacity barely decreases, and that's mostly, again, a result of decrease in expiratory reserve volume and the paralysis of abdominal muscles. You can, in rare circumstances, get full respiratory arrest, but that's due ultimately to a total spinal where you get hypoperfusion of the brainstem. It's not phrenic nerve blockade, really. It's actually the loss of all regulatory control of every body system because you have a total spinal, and you're not perfusing the brainstem more than anything else. Nausea, vomiting may be a complication of neuraxial anesthesia. It may occur in up to 20% of patients. May be related to hyperperistalsis because you invoke the sympathectomy, but you still have craniosacral outflow, which may have unopposed activity, and you get this hyperperistalsis as a result. Interestingly, anticholinergics like atropine appear to be effective in treating this. Overall, hepatic effects, there's a decreased hepatic blood flow, and that parallels the decrease in systemic vascular resistance. And there's some gastrointestinal effects. Ultimately, when epidural anesthesia is continued in the postoperative period, there may be a protective effect on the gastric mucosa because the intramucosal pH is higher during the postoperative epidural analgesia than compared to conventional systemic analgesia. Renal function, again, parallels systemic vascular resistance drops, and you get decreases in renal blood flow. So long as you maintain normotension during your anesthetic, it shouldn't be a problem. Urinary retention, however, is very, very common and can be a major cause of delay of discharge of outpatients who receive neuraxial anesthesia. You pretty much need to catheterize everyone's bladder when you do neuraxial anesthetic, with the exception of only the shortest acting local anesthetics like chloroprocaine or very, very low doses of bupivacaine or lidocaine. So there are block-related complications and drug-related complications. We don't typically use procaine anymore as a spinal anesthetic, associated with a higher frequency of nausea and high anesthetic failure rate and a slower time to recovery. Overall, it's the lower frequency of back pain and transient neurologic syndrome compared to lidocaine, but there are other alternatives there, so we don't typically use procaine very much anymore. Lidocaine is also chosen for shorter procedures that can be completed under 90 minutes, but like I said, higher rate of transient neurologic syndromes, which causes back pain radiating down the legs, but without any actual neurologic disorder, typically self-limited and treated with analgesics. Longer-acting local anesthetics like bupivacaine, ropivacaine, and levobupivacaine, levoisomer bupivacaine can be used. Although tetracaine gained some popularity for some time, we typically don't see its use very much anymore for long-acting analgesia and anesthesia under spinal anesthesia. You can make this last 4 hours or more in some cases with vasoconstrictors added, but most patients probably wouldn't tolerate a spinal anesthetic for that long. Overall, the difference between tetracaine and bupivacaine is minimal, and bupivacaine is a lot more accessible, and you can extend its duration a little bit with the use of epinephrine. Ropivacaine overall is gaining a lot of popularity because it has less cardiac toxicity and overall less motor block, interestingly, compared to bupivacaine. It's a little bit more expensive since it's not generic yet. It is less potent, so you do need almost 2 times the dose of ropivacaine, 1.5 to 2 times the dose, to produce a similar clinical effect. Levobupivacaine, again, similar to bupivacaine overall kinetically, less cardiac toxicity, but more expensive because it's the isolated isomer of the drug. So vasoconstrictors, always thought to increase duration of neuraxial anesthesia, which they do because you get less vascular uptake of the local anesthetic. But remember, there's a secondary mechanism, the alpha-adrenergic agonism that occurs with the use of epinephrine, for example, can influence nociception in a very adaptive way when you're giving it neuraxially. Overall, traditionally, epinephrine was thought to prolong tetracaine spinal anesthesia, but not bupiv or lidocaine anesthesia. The reason being is that tetracaine didn't really cause a whole lot of vasodilation, so you got a pure vasoconstrictive effect from the epi, whereas lidocaine and bupiv caused more vasodilation, and so the epi had to work to overcome that first before causing any real vasoconstriction. But overall, this is probably a nitpicky point, even though some textbooks say you don't really extend the lifespan of a spinal with long-acting anesthetics by adding epinephrine. Remember, there's still the analgesic effect of epinephrine, which augments the density of the block, which does influence duration overall. Primary disadvantage to using neuraxial neostigmine is which of the following? And by now you should realize that although neostigmine can be used neuraxially, it's not a popular technique primarily because it causes nausea. And that's the main detractor for its use. The two mechanisms of analgesia that occur when anticholinesterases are given neuraxially include, yes, the wealth of acetylcholine that develops in the gray matter or the lateral horn of the substantia gelatinosa of the spinal cord, which has antinociceptive effects, but also because, interestingly, these anticholinesterases actually invoke the release of nitric oxide, which also plays an antinociceptive role. And just to review the concepts of density and porosity, density is mass per unit volume. It's the weight in grams of anything per cc of volume. Specific gravity is the ratio of a density of one solution to another. And in clinical anesthesia, we use porosity as a ratio comparing the density of local anesthetic solution to CSF, essentially. And so a hypobaric drug has a porosity less than 1, whereas a hyperbaric drug is much higher than 1. So a common method for formulating hyperbaric solutions is simply to mix your drug with sterile water. Overall, there's some nuance in terms of how local anesthetics behave, as you can see in these other 2 bullet points, depending on the temperature at which you're at and so forth. Again, getting kind of, nitpicky here. I doubt that the ABA is going to ask you questions related to that. More so, you should just understand the concepts of porosity and how that influences where the local anesthetic is going to go once you inject it for spinal anesthesia. So next question, which of the following is most likely to influence the resulting peak block height of spinal anesthesia injection of local anesthetic? Height, weight, presence of a vasoconstrictor, or coughing or straining after a procedure? The most likely contribution is going to come from height. Okay. Interestingly, weight doesn't have as much of an influence as you might think on peak block height after spinal anesthesia. So, although some anesthesiologists do harbor some concern about giving the same dose of spinal anesthetic to an obese patient, a morbidly obese patient, overall, resulting peak block heights are comparative to normal weight patients. Height, however, does influence significantly, to some degree at least, what dose of drug you want to use. Overall effect is minimal compared to the total dosage of anesthetic that you use and the way you position them afterwards. So these tables show you all the factors that could potentially alter your spinal block height. Not all of them are reproducible or reliable factors that will alter your block height, but certainly worth considering when doing spinal anesthesia. The controllable factors, of course, the primary one is the dose that you give. Even site of injection, once you're in the CSF, everything's going to mix. The porosity, of course, alters how you can manipulate the patient's position to alter the resulting peak block height, as well as the posture of the patient. Obviously, you can't control for the volume of CSF or the density of the CSF fluid. These factors can influence peak block height, but probably unrelated, and that includes the use of vasoconstrictor, which affects density more than anything else, Valsalva doesn't appear to do anything. Barbotage, so constantly retracting and re-injecting CSF during the procedure, doesn't appear to do anything. Rate of injection may influence your peak block height if you're using a hypobaric solution and you're injecting fast, as well as facing your bevel up with the Whitaker needle may influence it. Gender and weight typically do not bear any effects on peak block height. So overall weight typically, like I said, not as related as compared to height, and the height itself has a relatively minor contribution. And the rest of this slide pretty much corroborates everything I just said in the previous slide. If you're given a list of choices of which affects peak block height of all of these things, height is more likely to affect it than injection rate, facing the needle bevel, or these other things. So these are the key points related to this section of this module. Move on to a little bit more in terms of complications and considerations for epidural anesthesia. The drug choice matters. Chlorprocaine had fallen out of favor for a long time because it caused two things, arachnoiditis and back pain, both of which were related to the preservative. The bisulfate tended to cause arachnoiditis. The EDTA caused the back pain. Since you find anesthesiologists now using chlorprocaine that's preservative-free, you don't see these effects anymore. So that's why we attribute all these to the preservative. So non-preservative chlorprocaine appears to be safe. And this is just referring to my comment about the EDTA, preservative-free chlorprocaine not associated with back pain. So lidocaine, very old drug, of course, and typically utilized in 2% solution for epidural surgical anesthesia. Mepivacaine, kinetically very similar, probably lasts a little bit longer when used interaxially. Epinephrine tends to prolong the mid-range local anesthetics a lot more so than the long-acting ones, as much as 50% or more with lidocaine and mepivacaine. Of course, for doing that, you might as well give bupivacaine. One technique that has been described to sort of help go along the resolution of motor block after surgery is to wash in 15 to 30 cc's of saline through the epidural catheter prior to its removal. So, quick question: which local anesthetic is the only one with that actually has vasoconstrictive properties? Of course, cocaine, we know, with its sympathomimetic effects, can cause vasoconstriction, but overall, ropivacaine, interestingly, doesn't seem to have the same vasodilatory effects as all the other local anesthetics. In fact, it has some mild vasoconstriction. Other notable qualities about ropivacaine when you use it as an alternative long-acting local anesthetic is that it has less cardiovascular toxicity compared to bupivacaine, and interestingly, less alpha motor neuron block compared to bupivacaine. So there's a lot of advantages to using ropivacaine. That said, it's less potent, requires more drug, and that's significant because if you're using a drug like ropivacaine that's higher cost, it adds cost to your management of the patient. Not going to say much about etidocaine since it's not really clinically used anymore. And this table gives you the available local anesthetics and their concentrations, the onset time for epidural anesthesia with plain and epinephrine-containing solutions, and their durations of actions respectively. So in terms of increasing duration of action and decreasing blood levels of local anesthetic, should you pick epinephrine versus phenylephrine? It's largely thought that epinephrine is far more effective at doing this than phenylephrine. And although some textbooks describe that epinephrine doesn't have much of an effect for long-acting local anesthetics like bupivacaine, remember there's that secondary mechanism of analgesia afforded by alpha adrenergic agonists like epinephrine, and so that might contribute additionally to the mild increase in duration that you can get with long-acting anesthetics containing epinephrine. Of course, carbonation of the local anesthetic can hasten onset, which is why we add sodium bicarbonate, typically 1 cc of sodium bicarbonate to every 10 cc's of local anesthetic, which alters the profile in a way that increases the non-protonated component of local anesthetic, which gains faster access to the myelin sheath and shortens the latency to nerve block, which is why carbonation works. So these are the key points that I wanted to make about this last section of regional anesthesia for the advanced exam. Again, I envision that the regional anesthesia components of the ABA exam are largely going to be related to peripheral nerve blockade, probably not so much with neuraxial anesthesia, but in studying neuraxial anesthesia, you should focus on the complications involved more than anything else, because this is a consultant level exam. You're expected to sort of encompass all the keywords on the ABA content outline here. But and corresponding with a lot of graduates over the years and those that have recently taken the advanced exam, most of them agree that peripheral nerve blockade is where most of your attention should be received. Thanks for listening.